Assalamu alaikum. Welcome back to Madzukhraf. Today I'm lecturing you on Giardia Lamblia. So let's get into the video. Morphology. First I'll tell you about trophozoites and then we'll talk about cysts. Trophozoites are tennis racket or heart-shaped. They vary from 10 to 20 micrometers in length and 5 to 15 micrometers in breadth. They are bilaterally symmetrical and two nuclei are present. 4 pairs of flagella are responsible for tumbling or falling leaf motion. Sucking disc is circular and situated on ventral surface of the parasite. It helps in its attachment to the ball wall or intestinal wall for the invasion. Cysts of Giardia lamblia are oval-shaped, 12 micrometers in length and 8 micrometers in width. 2 nuclei are present in immature cyst and 4 are present in mature cyst, but they remain clustered at one end. Flagella and sucking disc are maybe seen in cytoplasm of the cyst. Life cycle of Giardia lamblia. Trophozoites multiply by binary fission in the duodenum and upper part of jejunum of human beings, but this occurs in favorable conditions. Passes out into colon under unfavorable conditions and ancestation occurs. Ancestation means that trophozoites will get converted into cyst forms. During ancestation, a thick resistant wool is secreted and the cell is divided into two within the cyst, and cyst passes out in feces, and this is the diagnostic thing that we identify. Excistation occurs only when cysts are again ingested by man, and within 30 minutes of ingestion, 2 trophozoites hatch out from cyst and start their invasion process. Trophozoites then multiply and form colonies in the duodenum and upper part of jejunum. Habitat and transmission. First I'll talk about the habitat of trophozoites and cyst, and then we'll move on to transmission. Trophozoites have a definitive host, human being, as the Giardia lamblia lives in duodenum and upper part of jejunum, and the trophozoites have no intermediate host. Cysts. These are found in colon of man and in contaminated materials. These materials can be contaminated food or water. Transmission occurs by the ingestion of contaminated food and water, and the route is fecal-oral route. Next up is pathogenesis of giardiasis. This is a disease caused by Giardia lamblia. Infective agent for this is mature cyst, and infective dose is about 100 cysts of Giardia lamblia. Pathogenesis. Large number of trophozoites attached to the ball wall with the help of sucking discs that is present on the ventral surface of Giardia lamblia and cause irritation, low-grade inflammation of duodenal or jejunal mucosa associated with crypt hypertrophy, villus atrophy and epithelial cells damage, leading to acute or chronic diarrhea. Epidemiology. The organism is found worldwide. About 50% of the stool specimens in US, United States contain Giardia cysts. Approximately half of those infected are asymptomatic carriers who continue to excrete the cysts for years. Immunoglobulin A, IgA deficiency greatly predisposes to symptomatic infection. In addition to endemic, giardiasis occurs in outbreaks related to contaminated water supplies. Hikers who drink untreated stream water are frequently infected. Many species of human as well as mammals act as reservoirs. The incidence of giardiasis is high among children in daycare and among patients in mental hospitals, because both of the groups cannot take good care of their hygiene. Clinical findings in giardiasis. Diarrhea which is non-bloody and foul-smelling. Steatorrhea due to malabsorption of fats. Malaise. There is no fever in giardiasis. Weakness, anorexia. Weight loss, abdominal cramps and flatulence. Distension due to gas, nausea and vomiting. Chronic cholecystopathy, when parasite colonizes the biliary tract. Let me tell you how this happens. As we know that Giardia lamblia attacks the duodenum and upper part of duodenum. And in the second part of duodenum, the biliary duct opens. So when the parasite enters from duodenum into the biliary tract through this opening of the bile duct, it can cause cholecystopathy. Diagnostic laboratory tests. First, we'll collect specimens like stool, duodenal aspirate, and serum. Then we'll go for microscopy. In formed stools, only cysts are seen in asymptomatic cases. Finding trophozoites or